Good evening. Magandang gabi po, everybody. Welcome again to another session of PSD. And before we start, let us all bow down our heads in prayer. Dear Almighty and ever-loving God, we glorify and thank you. You have showered us with so much blessings. Your presence continuously reminds us of your faithfulness and guidance. We humbly ask you to shower our speakers today of your greatest inspiration so that they may share the most of their knowledge, heart, and soul to their respective topic. May we absorb the invaluable knowledge and put it into practice, what we may learn today. We pray that you bless all the committees in charge that they may be able to fulfill their tasks responsibly, that the objectives they have set may be all achieved. Your infinite blessing would mean the success of this activity. May we be living witnesses of your genuine love through the enactment of the knowledge acquired through this activity. We ask this in the name of our Lord and Savior. Amen.
Philippine Society of Diabetologists. The mission of PSD, the pursuit of excellence in diabetology. The vision of PSD, excellence in diabetology. Objective of PSD, to keep abreast of the most recent developments in all fields of diabetes research, education, and treatment. The PSD Statement of Purpose. The purpose of PSD is to give persons with diabetes lives with qualities unaffected by the condition. This is their right more than a privilege. This passion sustains and empowers us to find meaning and fulfillment. The purpose of PSD is to understand and accept that diabetes is a complex condition affecting an individual, the family, and community. Knowledge of its biomolecular and cellular origins and understanding all its interventions are as important as mastering its psychosocial dynamics. The purpose of PSD is to be a family of responsible persons bonded by one passion. Agreeing and disagreements strengthen our unity. Criticisms fuel our growth. Love fills our camaraderie. The purpose of PSD is to be a source of inspiration that informs, guides, and corrects one another in daily practice. We find happiness in sharing knowledge and experiences that improve patient lives. The purpose of PSD is to support individuals and organizations with similar noble goals, acknowledging that we all live in one world and fighting diabetes together multiplies good outcomes with a fraction of effort. Collaboration drives inspiration, motivation, and creativity. The purpose of PSD is to welcome the cure. When diabetes no longer exists, we will reincarnate with new passion and direction. Our vision will evolve with time, but the family lives on.
Good evening, everyone. Pakilala ko uli sa inyo ang current PSD Board of Directors. Our President is Dr. Baldemore. Our Vice President is Dr. Cruz. Our Secretary is Dr. Chu. Our Treasurer is Dr. Agra. And our Auditor is Dr. Dison. They are the working group of our board. I-welcome ko rin kayo sa ating PSD Select Lecture 4. Nasa Series 4 na tayo. Bilis ng panahon, ano? Umaga sa mga sine, sa mga nobela, naka 4 seasons na pala tayo. No? And the main objective of these lectures is to discuss updates in diabetes. And now, kasama dyan obesity, nutrition, and COVID-19. Kaya nag-evolve yan dahil sa COVID-19 Kaya sama-sama tayo virtually. This evening, we are sponsored, no, by Glorious Dexa Mandaya. And they will have two lecturers. A major breakthrough in improving blood circulation in diabetes, to be lectured by two of our own speakers. And then it will be followed by an update lectures on what has been discussed in ESD by an esteemed guest speaker, Dr. Itonwa. And after that, we'll have a short question and answer session so that if you have any inquiries, it can be addressed. We thank Glorious Dexa Mandawi Pharma for being our sponsor this evening. They are bringing to us new innovations in the treatment of diabetes complications. And these are going to be discussed by our speakers, our two initial speakers. And our speakers are our own. The first one is Dr. Marcy Cruz. She is one of the Board of Trustees of Diabetes Philippines. She is the President of Philippine Hospital Association Bulacan Chapter. She has earned her Masteral in Science in Internal Medicine major in Diabetology degree at the University of the East, MMC, ISDFI. She had her training in residency in Internal Medicine at Mary Johnston Hospital. She is now the Medical Director of Our Lady of Mercy Hospital, Incorporated. She is the President of the Board of Our Lady of Mercy General Hospital. She finished education of MBA Health at the Ateneo de Manila. She will be our first speaker. She is going to be followed by our own Dr. Danilo F. Baldimor, who is a diplomate and fellow of the Philippine College of Physicians and immediate past president of the PCP Central Luzon chapter. He is president now of our own Philippine Society of Diabetologists. He is the training manager of the ISD Center for Diabetes Care Networks of Clinics. He is a faculty of ISDFI, PSD, and PADE. He is a consultant at the Heart of Jesus Hospital, San Jose City, Nueva Ecija. Dr. PJG Memorial Medical Center. Oh, my colleagues, let's all listen to the lectures of our colleagues.
Sir Jan, no audio po. Sir Jan, no audio po. Pa-check po. No audio, sir.
Ikaw, Lynn, may copy ka?
Yes po, mag-share lang ako, Doc.
Ikaw na magbato.
Good evening, everyone. So hope everyone is healthy. Good evening, everyone. So hope everyone is healthy and safe. In diabetes. Our objectives is
Sir Jan, ako na po, wala pa ring audio. Pa-stop share, sir. Sorry.
good evening, everyone. So hope everyone is healthy and safe. Tonight we have a new topic, a major breakthrough in improving blood circulations in diabetes. Our objectives is to discuss the peripheral artery disease, its prevalence, causes, and association with diabetes, assessment and screening, as well as the treatment, including DISSOLVE. So what is peripheral artery disease? We know that diabetes has a chronic complications of macrovascular disease. And when we talk of macrovascular disease, we talk of stroke, heart attack, as well as peripheral artery disease. Peripheral artery disease is the blockage of blood vessels supplying blood to the legs and feet. This accounts for 80% of all diabetic mortality, 75% from coronary atherosclerosis, and 25% from cerebral or peripheral vascular disease. So we will discuss the prevalence of peripheral artery disease. The partners, which stands for PAD, Awareness, Risk, and Treatment, New Resources for Survival. They evaluated 6,979 patients in physician's office, which include 70 years old or 50 to 69 years old with history of smoking and or diabetes. And they have found out that 29% of which have PAD. 1 in every 3 people over ages 50 who have diabetes also have PAD as reported by IDF. Then the risk factor for PAD, we have smoking, diabetes, hypertension, hypercholesterolemia, CAD, and history of CKD. Another study that we could cite on the prevalence of PAD is the Asian Pacific Society of Atherosclerotic Vascular Disease. Here, they divided the patient into two. One patient is they observed the patient on community-based population, and the other one is the OPD patient with atherothrombosis or CB risk factor. What is the result? No? In community-based population, you can see that China had the most prevalent PAD, and the list is that of Japan, which is about 14%. However, when we have the OPD, it is a formal evaluation of PAD. Japan ranks the highest PAD, no? Prevalence of about 40%. What these do tell us that most of our patients are asymptomatic if they have PAD. It shows that PAD is best diagnosed if we have to evaluate as well as to investigate on our patients with diabetes. So definitely, patient with PAD will present as asymptomatic. Then how do we establish the diagnosis and assess its severity? So this is the anatomy of our lower extremities that shows you the most commonly affected vessels in PAD. So we have the aorta, the iliac femoral artery, as well as the popliteal, posterior tibial, anterior tibial, as well as the peroneal artery. So who are at risk to have PAD? So we have patients with atherosclerotic disease, other conditions such as abdominal aortic aneurysm, CKD, as well as patients with heart failure. Those patients who are asymptomatic and clinically free, but at risk for lower extremity atherosclerotic disease, age matters. So for ages more than 65 years of age, and for those lower than that is 50 to 64 years of age with risk factors for atherosclerosis like diabetes, history of smoking, hypertension, hyperlipidemia, and history of albuminuria or CKD, or family history of PAD. For patients less than 50 years old with diabetes and one additional risk factor for atherosclerosis. And lastly, atherosclerotic disease with other vascular beds, which include coronary, carotid, renal, or mesenteric. It has been said that most of PAD are really asymptomatic. So 1 in 5 people over 65 years of age has PAD. And only 1 in 10 of these patients has classical symptoms of intermittent claudication. So definitely, PAD is asymptomatic. Here is a pie graph showing to you the percentage of people who have variable presentation of PAD. 50% of which are asymptomatic, and 15% have typical claudication, 30% have atypical limb symptoms, and only 2 2 to 3% have critical limb ischemia. So definitely, they are asymptomatic. We have to look for them through our history and physical examination. These are the common findings in the history and PE suggestive of peripheral artery disease. So the clinical presentation, patients at high risk for PAD should be screened for exertional leg symptoms. Of importance, only a minority of patients with PAD will report classic intermittent claudication or present with ischemic rest pain. And other history findings that is suggestive of PAD, we have an intermittent claudication, atypical leg pain, functional impairment, especially sa matatanda nating pasyente na hindi na makalakad ng matagal kasi nangangalay. Then we have ischemic rest pain, history of non-healing wounds. Then on physical examination, usually we have the pulse assessment. We assess on the femoral, popliteal, dorsal pedis, or posterior tibial artery should all be examined. We have the pulses either as a 0 or absent, diminished, normal, or bounding pulse. But physical pulses examination is not enough. A handheld continuous wave Doppler may be useful to determine the severity of the disease. Bruit could be also suggestive of our peripheral artery disease. Again, skin examination is an essential part of our assessment. We could assess for arterial ulcer, which is common on the toes and bony prominences, typically painful. Then we have gangrene, molted skin, atrophic nails, extremity hair loss. No? Common yan sa mga diabetes. No? Pag nakikita natin, makikisap na yung skin. And also the discoloration, the peripheral discoloration or the distal discoloration of the skin. So, sino ba yung kailan ba natin dapat exam yung kanilang foot, no? If we have a patient who are low risk, we could examine them annually. But for patients who are high risk for ulcer, we may examine them more frequently every 3 to 6 months. For patients who presented as foot ulcer, we could refer them to professional team with expertise on foot ulcer. What are the diagnostic testing we could use? So commonly, we have in our office, we have the ankle brachial index. And the duplex ultrasound, usually, we request in our patients, ito usually pag nagre-request tayo, pag may foot ulcer na, no? Too late, it must be a strong suspicion on our part na meron sigurong PA dito. We must request for a duplex ultrasound immediately. We have other advanced imaging techniques. We have the computed tomography angiography, magnetic resonance angiography. So, the common of which is the ankle brachial index, wherein we have the ultrasound records BP in both arms, and BP in the ankle is recorded from one of these arteries, either the dorsalis pedis or the posterior tibia artery. They compare the blood pressure in your arms to the pressure in your ankle. And how to interpret? For diagnosis of lead, interpret each leg separately. 1 ABI per leg. For the CB risk stratification, take the lowest ABI between the two legs. Interpretation, we have 1 as normal ABI and borderline for a number of 0.9. But lower than 0.9, that is abnormal ABI or low. And higher than 1, like 1.4, is an abnormal ABI. So, what is the difference between arterial or venous ulcer? So, we have, for patients who have arterial, we have an intermittent claudication pain, no edema, no pulse or weak pulse, no drainage, round smooth sore with black eschar, and usually location of sores, toes, and feet. How about the venous, no? We have dull, achy pain, lower leg edema, pulse present and drainage, sores with irregular borders, yellow slot or ruddy skin, and the location of the sores are in the ankles. So, what happens to patients with diabetes and PAD? So, with this bar graph, we know that atherosclerosis started before the diagnosis of diabetes. That's why in this graph, you could see the prevalence of PAD in impaired glucose tolerance, which is about 19.9, at konti lang ang taas niya for patients with diabetes of 22.4%. So we could conclude that patients with impaired glucose tolerance and patients with diabetes have a very high prevalence of PAD. That's why we have to control our patients' glucose. It's very important. So with that, I turn on to you the management of diabetes with PAD with Dr. Danny Baltimore. Danny?
So good evening, everyone. So we would like to thank Glorious Dexa Medica for this lecture, and thank you to Dr. Marcy Cruz for the first part. And thank you also to our host moderator, Dr. Elvin Fernando. So to continue, how do we manage diabetes with PAD? So these are the recommendations in patients with peripheral arterial disease based on the European Society of Cardiology guidelines on the diagnosis and management of peripheral arterial disease. So, syempre, importante, smoking cessation is recommended in all patients with PAD, as well as healthy diet and physical activity are recommended for all patients. Ngayon, kung ang patient natin ay may PAD na, the statins are recommended in all patients with PAD. And if you want to target the LDL cholesterol, you need to target it at less than 70 milligram per dm. Now, in patients with diabetes and also with PAD, strict glycemic control is recommended. We give antiplatelet therapy for patients with symptomatic PAD. Okay, ngayon kung ang patient natin din naman ay hypertensive, then it is recommended to control the blood pressure at less than 140/90 and to use an ACE inhibitors or an ARBs. Now, we know that diabetes is a prothrombotic state. It is characterized by accelerated atherosclerosis and inflammation. So, in diabetes talaga, hypercoagulable state siya. So, nagkakaroon ng decrease in fibrinolysis and increase in coagulation. So, coagulation is higher than fibrinolysis. So, how to reduce the risk of thrombosis? So, if your goal is to prevent the initial clot formation, you give the patient an antiplatelet. Okay? Now, if your goal is to prevent the progression of thrombosis, you give the patient with anticoagulant. And if your goal is to degrade fibrinogen or fibrin or eliminate the formed clots, then you give a fibrinolytic. So just to show you the classification of antithrombotic drugs. Kaya minsan, nagbabara tapos nagbigay ka ng isang gamot, but after a while, nagkakaroon pa rin ng recurrence or nagkakaroon ng bagong bara. So listed here is the antithrombotic drugs. You have your antiplatelet, you have your anticoagulants, and you have your fibrinolytic agents. So now I'll introduce to you yung dissolved. So it's bioactive protein fraction or your DLBS 1033. So it's a major breakthrough in improving blood circulation in patients with diabetes. It is a natural product composed of a natural enzyme called your lumbrokinase. So it's very unique because it has 8 major proteins with molecular weight of less than 100 kilodaltons. So ang tawag din sa kanya, lumbricus low molecular weight protein. So syempre, mas maganda yung mga low molecular weight protein kasi it goes to the blood vessels. So let's talk about the mechanism of action. So your dissolve again is antithrombotic and has a thrombolytic effect. Pag sinabing antithrombosis, it has been shown that it has an antiplatelet aggregation and fibrinogenolytic activity. The thrombolytic activity, it lyses the clot and it has a fibrinolytic activity. So your dissolve is a potent fibrinolytic and fibrinogenolytic activity. So it lowers down the viscosity of the blood as well as reduction in the platelet aggregation. So isa-isay natin kasi 4 yung mechanism niya. So as an antiplatelet aggregation therapy, so it is similar to silostazole but it has a better potential in inhibiting the phosphodiesterase 3. So yan ang ini-inhibit ng dissolve para hindi mag-continue ito at hindi magkaroon ng platelet aggregation. Next, it also it can decrease the blood viscosity level. So yung fibrinogenolytic activity has been done using a zymogram method. So in-inhibit ng dissolve yung fibrinogen going to fibrin. Okay, so it prevents the formation of fibrin and can decrease the blood viscosity level. Next, it acts on the tissue plasminogen activator and plasmin. So yung fibrin, ito yan. So your dissolve degrades the fibrin in the soluble peptides and this potentiate into fast-acting and long-acting fibrinolytic activity. So maganda siyang gamitin natin because the volume of the fibrin is lysed by the dissolve. Kaya yan yung tinatawag natin fibrinolytic activity. Lastly, okay, your dissolve, because of its low molecular weight, it can penetrate into the blood clot and cut the fibrin and at the same time dissolve the clots. Okay? Now, let's proceed with how do we use dissolve in peripheral arterial disease. So it is indicated again in improving the blood circulation. So ginagamit natin to as a primary prevention for patients who are at high risk, like patients with diabetes, dyslipidemia, hypertension, and those who are smokers. As a secondary prevention, based on mga studies nila, it is also it has been used for patients with cerebral infarction, particularly yung mga ischemic stroke, those with myocardial infarction, with coronary arterial disease, and syempre yung PAD, like your DVT. So how do you give this dissolve? So as a therapy o yung sa prevention or secondary prevention, you give it at 1 tablet 3 times a day. Now, for prevention, it is used as 1 tablet 3 times a day. The contraindication, syempre yung mga patients natin na merong blood coagulation abnormality, we have to be cautious or iiwasan natin silang bigyan nito. At yung mga pasyente rin natin na may known allergy to any of its components. Okay? So yung mga bleeding tendencies din, mag-ingat din tayo sa pagbibigay ng dissolve. So siguro, can we combine it with other anticoagulant agents? So pwede natin i-combine with aspirin, or we can combine it with clopidogrel, or we can also combine it with sulostazole. So ganyan yung gamit natin with dissolve. So for the next few slides, we will be talking about its clinical cases. Okay, yung clinical use pala. So I'll be presenting 2 cases so that I have seen in our clinic. So this is a 73-year-old female who has been diabetic for 33 years. Very strong ang family history niya kasi yung mother, sisters at yung brothers niya, halos lahat merong diabetic. So she came because of a non-healing wound on the left foot for 6 months. Okay, the initial blood pressure is controlled naman 130/80. The fasting blood sugar is 166. However, the A1C is very high at 9.1%. The eGFR is at 25 ml per minute from a creatinine of 171. So medyo compromised na rin yung kidney function niya. Okay, so the patient was started with a DPP-4 inhibitor and a basal insulin. So ganito yung itsura na sugat ng patient. Okay, so last May or last year. So after giving her dissolve, okay, so lumbrokinase at 1 tablet 3 times a day, syempre yung daily wound care din, and then adjusted yung mga gamot niya sa diabetes to control. Her A1C last July 22 is already at 6% and the fasting blood sugar is 120. So ganito na po yung itsura ng sugat niya at the time of the check-up. Okay? For the next case, this is very common among our patient. So this is a 42-year-old male, newly diagnosed diabetes. Okay, so he came because of a non-healing wound on the right foot. So usually ito naman sa daliri, ingrown, di ba? So he has an ingrown toenail for a month already. So on checkup, ang fasting blood sugar is around 256 and the A1C is about 10.8%. So I started him on an SGLT2 inhibitor and metformin combination. Dinagdagan ko na rin siya ng basal insulin. And then, ang kidneys naman niya okay. Okay, so patient was given dissolve at 1 tablet 3 times a day. And then on follow-up, okay, so after mga 1 to 2 weeks, ganito na po yung itsura ng sugat niya. Okay? So, ang maganda dito kasi nag-improve yung sugar, nag-i-improve din yung sugat ng mga pasyente natin. So, ang napansin ko lang din, it shortens the length of yung paggaling. Okay? So, mas umiiksi, mas mabilis gumagaling rather. Okay? Now, so to wrap up, this is the summary slide. So we have already discussed yung peripheral arterial disease by Dr. Marcy Cruz, its prevalence, the causes of and association with diabetes, as well as some tips on the assessment and screening. And I have discussed treatment, including dissolve, and shown you some cases. So these are the key points we would like to end this lecture. So blood flow is restricted to the tissue because of spasm or narrowing of the vessels. So this disease more often affects the blood vessels, usually in the legs. And the most common symptom is pain, which becomes worse as the circulation is more limited. But again, take note, hindi lahat ng may peripheral arterial disease would complain of pain. So we need to screen our patients. So restoring the blood flow and preventing the disease progression is the goal of the treatment. So again, peripheral vascular disease can also affect all types of blood vessels. And with your dissolve, it's a major breakthrough in improving the blood circulation in patients with diabetes. And with that, we would like to thank you all for your attention.
Thank you for those lectures. Those are the first 2 lectures for this evening. And now we are going to be graced by an esteemed, special, great speaker. He is well known to all of us. He is an icon in diabetes and endocrinology in the Philippines. He is the founder of the PSEM, now PSEDM, and is known as Father of Philippine Endocrinology. He founded also the Philippine Association for the Study of Overweight and Obesity. He is past president of Philippine College of Physicians, a founder of the AACE Philippines, an outstanding service awardee for the promotion of endocrine health of the underserved population. It was given by the American Association of Clinical Endocrinologists, Seattle, way back in 2007. He earned the International Clinician Award from AACE in 2012. He is past president of Diabetes Philippines, Philippine Diabetes Association then, for 11 years. He has earned the Lifetime Achievement Award from the University of Philippines alumni for 2 years, 2012 and 2013. He is an emeritus professor of the College of Medicine. He is an active consultant now at the Makati Medical Center and Asian Hospital and Medical Center. So friends and colleagues, let's all welcome Dr. Augusto Litonwa.
This is the topic of my this is the topic of my lecture today. My registration to the 2021 EASD was sponsored by Sanofi, and this webinar today is an excerpt from the original, which was a joint project of the Philippine Center for Diabetes Education Foundation Incorporated and Sanofi Aventis Philippines Incorporated. This is the outline of my talk. And the first topic is NAFLD to MAFLD, non-alcoholic fatty liver disease to metabolically associated fatty liver disease. And why the change? This was a lecture of Dr. Luca Valenti, and MAFLD means metabolic dysfunction associated fatty liver disease, in contrast to NAFLD, which is non-alcoholic fatty liver disease, because fatty liver disease involves a lot of other diseases, alcohol, autoimmune, viral, and so forth. The term fatty liver was first used in 1845, and NAFLD and NASH were introduced in 1980, and they removed alcoholic fatty liver disease, and the term and non-alcoholic fatty liver disease was coined. NAFLD is supposed to go to steatosis or NAS. But before 2020, they removed NAS. And so it was only steatosis, and that became muffled in 2020 by an international consensus. In the future, supposedly, muffled patients will be divided or subtyped into diet, alcohol, microbiota, genetics and epigenetics, metabolic health. How do you diagnose muffled or metabolically associated fatty liver disease? First, you have to demonstrate that there is fat in the liver by imaging techniques, biomarkers, scores, or by histology. When that is associated with overweight or obesity, that becomes muffled. When it is associated with diabetes mellitus, that again is muffled. But there are many patients with fatty liver who are lean or with normal weight, and that is defined as less than 23 kilograms per meter squared in Asians. If they are associated with at least two of these metabolic risk abnormalities. What are they? A big waist circumference, equal to or greater than 90 in men, equal to or greater than 80 in Asian women. Blood pressure of equal to or greater than 130/85, if or also they are on specific drug treatment. Plasma triglycerides of equal to or greater than 150 milligrams per deciliter or under treatment. Plasma HDL cholesterol less than 40 in men, less than 50 in women, or under treatment. Pre-diabetes and homeostasis model assessment or HOMA-IR of equal to or greater than 2.5. And finally, if associated with plasma high sensitivity C-reactive protein equal to 2 milligrams per deciliter. The term muffled improves the detection of high liver stiffness in the Rotterdam study. This involved about 5,445 patients with fatty liver or no fatty liver, and those with fatty liver, only 1% were NAFLD, non-alcoholic fatty liver disease, and 5.5% muffled. So here is the overall division of these 5,400 patients, 214 with muffled only, 42 with NAFLD only, and there was an overlap of 1,048. Now, how many had fibrosis or liver stiffness of equal to or greater than 8 kilopascals? Muffled only 31 in the 214 patients, NAFLD none in the 42 patients, and in the overlap 111. So you can see the greater detection of fibrosis when you use the term muffled. In the Japanese study, again, there are patients who had NAFLD only, overlapping, muffled only. You can see that the significant fibrosis detection was increased by 20% in contrast to NAFLD. Muffled was those patients with hepatic steatosis who are overweight and obese, with metabolic dysfunctions, with type 2 diabetes mellitus. NAFLD excluded alcoholic fatty liver disease, viral hepatitis, and autoimmune liver disease. So now that changes who are to manage fatty liver disease. Previously, it was only the hepatologist. Now it's a multidisciplinary approach involving the general practitioner, the hepatologist, the endocrinologist, the internist, nutritionist, pathologist, nephrologist, and cardiologist, because fatty liver has extra liver metabolic dysfunctions. Why the change from NAFLD to MAFLD? Because we are moving to a positive definition. We are avoiding stigmatization, increasing the patient's understanding and adherence to therapeutic strategies. Thirdly, there is an unreliability of alcohol history, and there are arbitrary thresholds of alcoholic intake. There is individual variability. There is no safe limit of alcohol use, and there is a synergistic effect of alcoholic dysfunction on fatty liver disease. There is a similar pathophysiology among the different causes of fatty liver disease. They have shared mechanisms, shared genetics, and there is a likely role of endogenous alcohol production even in total alcohol abstainers. And we now get an improved ability to identify individuals at risk for progressive liver disease. So the key points are, among individuals with this metabolism, those with type 2 diabetes and more severe insulin resistance are at highest risk for NAFLD or MAFLD, leading to cirrhosis and hepatocellular carcinoma, and they should be screened by a multidisciplinary approach with assessment of liver damage together with extra hepatic involvement. By a stepwise approach, first-line application of simple non-invasive scores, followed by biomarkers or imaging, and eventually biopsy when needed. Although a broader consensus by all stakeholders in the field is still needed before a definite change in fatty liver definition from NAFLD to MAFLD can be implemented, the publication of this first statement signed by a large international expert panel represents an initial step in this process. Second topic, glucose control in the ICU, tight or not too tight. These are studies from the clinics of Dr. Leuven in Belgium. And conventional is represented by the green color. It is those patients who are given insulin only if the blood glucose rises to 250 milligrams per cent. Intensive is when yellow is when the patients are kept at 80 to 110 milligrams per deciliter. You can see that conventional insulin treatment produces a greater number of new kidney injuries than the intensive. And then there is this neuropathic complication seen in the ICU, which increases with conventional treatment, lesser with intensive control. So what makes up for the survival effect? Is it the glucose level, or is it the amount of insulin that is given? This study cannot be done in humans, of course, and so they duplicated this study in rats, replicated the conditions in the ICU. These patients, some of these rats were kept at normal glycemia by the glucose clamp of Defronso. And as you can see, the survival was the same, even if in those patients given normal insulin or high insulin. But when these patients, when these rats were kept at hyperglycemic levels no matter what the insulin levels were, the survival was less as compared to the normal glycemic groups. So the answer is, it is glucose control that determines survival. Strict blood glucose control with intensive insulin treatment improves leukocyte function, reduces inflammation, reduces endothelial activation, improves cardiac contractility, prevents dyslipidemia, protects the central and peripheral nervous system, and finally improves liver, kidney, mitochondrial structure and function. How tight is tight enough? In retrospect, post-hoc comparison of ICU patients in the medical and surgical ICU units, numbering about 3,000 patients, divided into those treated or whose blood glucose values were kept at less than 110, yellow, between 110 to 150, pink, between greater than 150, green. Cumulative risk of in-hospital mortality greatest in the more than 150, least in the less than 110. Percent new kidney injury, least in the less than 110, greatest in the 150. And neuropathies, least in the less than 110, greater in the 150, and greater than 110. How about in the pediatric ICU? What is tight, what is not tight? Tight in those less than 1 year of age, infants, 50 to 800 to 80 milligrams per deciliter as compared to conventional 150 milligrams per deciliter. Children aged greater than 1 year, 70 to 100 was the intensive, and conventional was 148 milligrams per deciliter or above. So in that study, pediatric intensive pediatric ICU, there was reduced morbidity in terms of shorter ICU stay, reduced inflammation, protection of the heart, lesser episodes, fewer ICU infections, the blue, lesser. Then also, in the ICU, it's not only the glucose control that is important, but also is there harm from whether you give early or late parenteral nutrition in adults or in pediatric patients. These were the two studies published in the New England Journal of Medicine. In the adults, fewer infections with late parenteral nutrition, higher infections in the early parenteral nutrition. In the pediatrics, the same. Late parenteral nutrition, lesser infections, early parenteral nutrition, greater infection. What is early? Less than 3 days, and what is late? About 3 to 8 days. Now, why is there greater morbidity in those with late, in the early parenteral nutrition? Well, critical illness produces inflammation, hypoperfusion, hypoxia, resulting in the induction of damage to the tissues, and also stimulates autophagy, or the removal of the damaged particles by phagocytes, and then the entry of lysosomes into these phagocytosomes, and you get lysis of the bad particles inside the outer lysosome. However, if there is hyperglycemia, you produce more induction of damage. And if there is early nutrition, the macronutrients will defer damage removal. So the reason why late parenteral nutrition produces less morbidities than early parenteral nutrition in the ICU. Next topic, diabetic kidney disease. This is the glomerular capillary wall, podocytes, and their finger-like projections around the basement membrane of the glomerulus, then covered by glycocalyx, the violet ones. There's also an glycocalyx inside the glomerulus. Then this is the basement membrane, the orange one, and this is the endothelial cells and the mesangial cells. Then there are slits here, which are determined by the finger-like projections of the podocyte, as well as the charges induced by the electrical charges induced by the glycocalyx. GFR and urinary ACR are largely determined by the glomerular capillary wall. GFR depends on the dimensions of the cell membrane free path across the glomerular capillary wall. The urinary creatinine ratio, albumin creatinine ratio depends largely on the endothelial glycocalyx as part of the integrated functional unit of the glomerular capillary wall. In diabetes, GFR is reduced by loss of the fenestrations here, fenestral diaphragms, GBM thickening, glomerular basement thickening, podocyte effacement. These finger-like projections are effaced and die, and glomerulosclerosis. In diabetes, the urinary albumin creatinine ratio is increased by glycocalyx damage and disruption of the podocyte effacement here. The podocytes determine the sizes of the pores, also by the electrical charges carried by the glycocalyx. So, if you compare with healthy individuals, if you have CKD, chronic kidney disease, or diabetes, would that shorten your life expectancy? If you have early CKD, if you are a woman, you lose 6.7 years of your life, 5.7 years if you are a man. If you have diabetes, 11.7 years of your life are lost. 10.2 years are lost if you're a man. If you have both, 17 years lost in women, 15 years lost in men. Now, CKD, chronic kidney disease, is driven by three factors. Hemodynamic, which is elevated blood pressure or elevated intraglomerular pressure. By metabolic, the glycemic control, and inflammation and fibrosis, which drives these changes in the kidneys, tubulointerstitial damage and inflammation, glomerulosclerosis, mesangial expansion, glomerular hypertrophy, which drives kidney to produce fibrosis, and that leads to the progression of chronic kidney disease. At this time in the Philippines, we have these agents that will correct the hemodynamic dysfunction in the kidneys, ACE inhibitors, ARBs, which affect the efferent arteriole, the SGLT2 inhibitors, which affect the afferent arteriole, and then metabolic, the anti-hyperglycemic agents, together with SGLT2 inhibitors and GLP-1 receptor agonists. Why don't we include these two agents as anti-hyperglycemic agents? Because they are more of a cardiorenal agent than anti-hyperglycemic agents. Anyway, these three correct the metabolic dysfunction in the kidney. Inflammation and fibrosis. In the United States, they are now using finerenone. We don't have this agent in the Philippines. What is finerenone? It's a metabolic receptor antagonist, MRA, because in the kidneys you have these mineralocorticoid receptors, which are activated by aldosterone or cortisol together with their cofactor. And this mineralocorticoid receptor overactivation results in the transcription of pro-inflammatory and pro-fibrotic genes, so causing inflammation and fibrosis in the kidneys. In the glomerulus, podocyte, mesangial cells, macrophages are affected. In the proximal collecting tubules, macrophages, fibroblasts. In the distal collecting tubules, the epithelial cells are injured, and that causes the urine to have elevated albumin. Finerenone is an antagonist to the mineralocorticoid receptor, so that it exerts its effects by blocking the transcription of pro-inflammatory and pro-fibrotic genes in various cell types of the glomeruli in the kidney, causing anti-inflammatory, anti-fibrotic actions on the glomerulus, on the proximal collecting tubules, in the distal collecting tubules, and the urine is now with reduced albumin. So these are the studies involving finerenone. The studies are called Fidelio DKD, cardiorenal outcomes in people with high-risk CKD and type 2 diabetes mellitus. As you can see in these studies, finerenone had consistent effects on kidney outcomes, greater than or equal to 40% reduction in eGFR, composite, reduction in kidney failure, reduction in the eGFR from baseline, reduction by equal to or greater than 57% of eGFR kidney composite outcomes, 57% decrease in eGFR from the baseline. The summary of these studies, finerenone reduced the risk of CKD progression in comparison to placebo by 18%. Finerenone reduced the risk of cardiovascular events against placebo by 14%. Finerenone was effective for the prevention of cardiovascular events irrespective of a prior CVD history. Finerenone, therefore, has kidney and cardiovascular benefits, consistent irrespective of the baseline A1C, and were seen independent of and in combination with commonly used glucose-lowering medications. Now, how about combination with SGLT2 inhibitors? This was an analysis of the Figaro DKD study. And again, you have these drivers of CKD, hemodynamic, metabolic, corrected by SGLT2 inhibitors. Inflammation and fibrosis now corrected by this new mineralocorticoid antagonist finerenone. In rats, if you have empagliflozin, SGLT2 inhibitors, you reduce your urinary protein creatinine ratio, as you can see here, 10 milligrams, 25 milligrams of finerenone, and of empagliflozin. With finerenone, you also reduce the urinary protein creatinine ratio, and the combination of both has the same effect as finerenone alone. How about cardiac fibrosis? Empagliflozin, SGLT2 inhibitors, reduces cardiac fibrosis. Finerenone does that also, and the combination of the two produces a greater effect. How about survival? The combination of the two produces the greatest survival among the users of empagliflozin or finerenone or placebo alone. So here in this study, if you have a patient with a baseline of treatment without SGLT2 inhibitors, but with finerenone, you reduce your urinary albumin creatinine ratio by 32%. If you add on SGLT2 inhibitors, the reduction in DKD events is increased to 41%. Next topic, next step in incretin therapy. We are using GLP-1 receptor agonists, believing that it has the most beneficial human effects, as well as it is the major incretin in the humans. However, we are now finding that GIP is the major incretin in humans and has more beneficial effects than GLP-1. GLP-1 receptor agonist on the central nervous system increases satiety, decreases food intake, but increases nausea and reduces body weight. In the pancreas, increases insulin, decreases glucagon. In the stomach, decreases gastric emptying, systemically reduces the hyperglycemia. In the liver, increases insulin sensitivity, decreases hepatic glucose production, and decreases ectopic lipid accumulation. How about the GIP receptor antagonist? In the central nervous system, decreases food intake, but decreases nausea. So together with the GLP-1 receptor agonist would have no nausea effects. It also decreases body weight. In the pancreas, increases insulin and glucagon. So again, that is a combination effect with GLP-1. The glucagon is not affected. Then subcutaneous white adipose tissue increases insulin sensitivity, increases the lipid buffering capacity, increases blood flow, increases storage capacity, and decreases the pro-inflammatory immune cell infiltration. Systemically reduces hyperglycemia and dietary triglycerides. Dietary triglycerides refers to the postprandial triglycerides or chylomicron triglycerides. In the skeletal muscles, GIP increases insulin sensitivity, increases metabolic flexibility, and decreases ectopic lipid accumulation. So combining the two, you have greater beneficial effects, as you can see in this study, compared to semaglutide or Ozempic, 1 milligram, and tirzepatide, the combination of GLP-1 receptor agonist and GIP receptor agonist, 15 milligrams. A1C is decreased greater than with semaglutide. Body weight, also there is a greater decrease in body weight with tirzepatide as compared to Ozempic 1 milligram. But there is a greater beneficial effect with the combination of GLP-1, GIP in tirzepatide. It is in the reduction of the mean amplitude of glycemic excursions, which accounts for one of the reasons for the diabetic complications. When you use 5 milligrams of tirzepatide, you reduce mean amplitude of glycemic excursions, abbreviated to MAGE, by 26.2. If you use a bigger dose, 10 or 15 milligrams, they're almost equal, minus 40 or minus 39. So 10 milligrams is the maximum dose that gives us the most beneficial effect. Now you compare that with insulin degludec, plus 40 mean amplitude of the glycemic excursion. So the reduction of the MAIDs is a very great beneficial effect towards reducing diabetic complications if you use the combination of GLP-1 receptor agonist and GIP-1 receptor agonist. And very remarkable, here we see the effects of tirzepatide 5 milligrams added to metformin and SGLT2 inhibitors in those with hepatic steatosis, liver function, fat concentration, 27.3% in this patient. No? At baseline, you can see that the reddish are the fat accumulation. And at 52 weeks, the liver fat accumulation is reduced to 2.6%. This is now the liver becomes bluish in this illustration. Not only that, BMI from 45 kilograms per meter squared down to 36.2 kilograms per meter squared. Body weight, 134 kilograms down to 108 kilograms. Waist circumference, 140 centimeters down to 125 centimeters. A1C, 9.3% down to 6.1%. Fasting serum glucose, 186 milligrams per deciliter, down to 107 milligrams per deciliter. So very great beneficial liver antidote to its fatty accumulation. On the heart, the first occurrence of MACE as compared to insulin glargine, pooled tirzepatide, the occurrence of the MACE4 is much later than that of insulin glargine, as you can see here. Now, can tirzepatide be an obesity treatment because of the great weight loss that it produces? Let's compare that to the 3 kinds of bariatric surgery here, which produces this amount of weight loss. At the moment, semaglutide, the 2.4 milligrams, which is not available in the Philippines, and the tirzepatide, 15 milligrams, still produces a lesser weight loss than any of these 3 bariatric surgery. So probably higher dosages are needed, and this can be evaluated by future studies. The last topic, prediabetes, innocent or guilty. If you cannot remember any of these lectures except prediabetes, I think that our time is well spent, because prediabetes is not a benign condition. It is simply early diabetes. And these are studies from the University of Maastricht, where they used, first, this is the prevalence of prediabetes, which is related to the body weight. The greater body weight, the greater the prevalence of prediabetes, and the prevalence goes down with the decrease of body weight. If we look at the etiology of vascular disease, in these 50 studies involving 6,211 deaths related to the mean fasting plasma glucose, you can see that the vascular death occurs most in those people with the greatest mean fasting plasma glucose. These are the diabetics. And the in-between normal and diabetic values, pre-diabetics, also a high incidence of vascular death. So pre-diabetes is also one of the causes of premature vascular death. Do people with pre-diabetes have microvascular dysfunction? If so, how widespread is it? How severe? Does it relate to measures of glycemia? The means by which they studied this were rather sophisticated. In the retina, they determined the diameters, tortuosity of the vessels, fractals, flicker light-induced dilatation. In the brain, the amount of white matter, hyperdensities, cerebral microbleeds, lacunar infarcts, atrophy. In the sublingual area, glycocalyx. In the plasma, biomarkers, especially those adhesion molecules. In the urine, the amount of albuminuria. And in the skin, capillary density, flow motion, and heat-induced hyperemia. So sophisticated studies. And what did they find? There was retinal arterial, increased retinal arteriolar diameters in those with diabetics in these two models, and almost none in the normal glucose patients. But in prediabetics, you also get retinal arteriolar diameters, which are increased. As you can see here, as the amount of A1C increases, the arteriolar diameter also decreases. So with the retinal venular diameters, the same results. Diabetics, pre-diabetics, normal blood glucose in two models. How about vasodilation in the retina? That is impaired in diabetics, not in normal glucose levels, but also impaired in pre-diabetics. In the skin, the same, diabetics, pre-diabetics, normals. How about the cerebral white matter hyperintensities, representing probably infarcts? There is a greater white matter hyperdensity in type 2 diabetes, least in normal glucose levels, and in pre-diabetics. You also have an increased cerebral white matter hyperdensity. How about the volume of the white matter? There is a volume loss in type 2 diabetes as compared to those with normal glucose measures. But you also get a loss of white matter in pre-diabetics. How about the impairment of the peroneal nerve? Impaired in type 2 diabetes. Also impaired in pre-diabetes, although much less, but greater than in normal people with normal glucose levels. How about in the large fiber, the tibial nerve? Also the same results. Diabetic, pre-diabetic, normal glucose individuals. How about the autonomic nerves going to the heart? Same results. Diabetic, pre-diabetic, non-diabetics. So there are impairments of the nerves, of the small nerves, peripherally in the heart. How about the nerve fiber length that is reduced in type 2 diabetes, not in those without diabetes, but also reduced in pre-diabetics? How about the thinning of the retinal nerve fiber layer around the optic disc, much reduced in diabetics, not in non-diabetics, but also reduced in pre-diabetics? Retinal neurodegeneration is associated with brain atrophy. So you can see here that those with retinal neurodegeneration, the brain atrophy is seen by the reduction in these layers of the different layers of the brain, gray matter, white matter, hippocampus, and the brain volume and total. There is a risk of depression when there is retinal neurodegeneration. The hazard ratio and the relative risk. retinal neurodegeneration is associated with a 7-year incidence of depressive symptoms. So diabetes is a progressive macrovascular, microvascular, and neuronal disorder. And that affects many organs. And that starts in pre-diabetes. So we must manage pre-diabetes strictly as we manage diabetes itself. I would like to quote Sir William Osler. He said, "It is much more important to know what sort of a patient has the disease than what sort of a disease the patient has. The good physician treats the disease. The great physician treats the patient who has the disease." With that, thank you for your attention.
Thank you very much, sir. That was a very excellent and scholarly update on what is new in the world of diabetology and endocrinology. We are now opening the floor for questions from among our listeners. And I think there are some questions listed here, sir. And Dr. Litonol will be gracing us by answering some of the questions that are listed here. Sir, one of the questions is about the liver, the NAFLD to MAFLD. While there is a significant change in name and a very, very good explanation for the change in the name, is there also a change in the treatment or in the intervention of liver disease in these individuals? Meron ba sinabi, sir, na change in the treatment?
There is no change in the treatment, but before we remove alcoholic fatty liver disease, because we thought that they had different pathologic mechanisms and probably different modes of treatment. But now it seems that alcoholic fatty liver disease is the same as non-alcoholic fatty liver disease. So pareho din yung gamutan. Kaya lang, mas marami na tayong nai-include na pasyente na may fatty liver disease, whether alcoholic or non-alcoholic, genetic or non-genetic, and so forth. And so with the increase in the number of fatty liver disease, we now are more aware of the numbers that will become fibrotic, cirrhotic, and then carcinogenic.
That's a very significant knowledge, new knowledge there. Oh, here's another question from the audience. This is about the ICU glycemic control. Parang bumalik sa dati daw na it's better to control the blood sugar to something like 110 and below because at the moment, no, ang maraming nagme-maintain sa ICU to something like 120 to 160 or even 180. Well, of course, it will still change through time, and we appreciate, of course, the new results of the clinical trials. But did they mention anything about how to control the blood sugar very, very strictly in the ICU? Did they mention new protocols in insulin drip? Did they mention new monitoring devices for continuous monitoring of blood sugar while in the ICU? Meron daw bang ganun, sir?
No, wala. Wala naman. Kaya lang, I also cannot understand why Dr. Vandenberg, who reported this as early as 2010,
yes,
and then has 4 articles in the New England Journal of Medicine up to 2021. I don't know why she is using the arterial blood glucose rather than the venous blood glucose in her studies. That I cannot understand. Perhaps in the starvation state, the amount of glucose in the arteries is almost equal to that of the venous blood glucose. Pero ang pinaka-importante siguro na dapat natin alamin, pagka very strict tayo in the control of hyperglycemia, up to 80 to 110 milligrams per cent, ano yung kinatatakutan natin? Hypoglycemia. So, is there a greater number of hypoglycemics in Vandenberg's method, 80 to 110 milligrams per cent, in contrast to that of a greater level of blood glucose control? And Dr. Vandenberg says, yes, she has more hypoglycemics. But the way she controls hypoglycemia results in a better outcome in the patients than in the higher blood glucose control with lesser hypoglycemia. So the difference is in this, no? Kung meron tayong hypoglycemia, napaka-vigorous ang treatment natin ng hypoglycemia. Bigay tayo kagad ng 50 grams of dextrose. No? Sa kanya, hindi. Ang sabi niya, when she has hypoglycemia, she has a very gentle way of recovering from hypoglycemia, meaning to say that she doesn't go over 140 milligrams per cent when she corrects the hypoglycemia. So instead of giving the whole vial of 50 grams of dextrose, you give only 10 cc, 20 cc, konti lamang. Pero several times you check the blood glucose every 30 minutes or every 1 hour, and then give another small dose of glucose IV injection. So she has a study also on that, no? Compared to the NICE, NICE method of correcting the hypoglycemia. The National Institute of CE of Critical Care, I think, or so.
That is very significant, sir. Thank you very much for those new knowledge. No? Siguro, sir, kung every 10, every 15 minutes na-check ng blood sugar, maybe they are using continuous glucose monitoring na. Baka lang.
Kaya labang, ang problema ng continuous glucose monitoring, in my experience, no, is mas mababa kaysa doon sa finger prick. Kasi yung finger prick is directly sa blood, capillary blood. Yung continuous glucose monitoring sa subcutaneous tissue or interstitial tissue. So there is a lag between the occurrence of the blood glucose in the interstitial tissue and the blood glucose. So we must be aware of that, the blood glucose values that the subcutaneous, that the continuous glucose monitoring gives us is lower than the finger prick method.
Thank you, sir. Are there any more questions? Oh, here. Thank you. Another one. Another question. It's about diabetes kidney disease and a very new exciting intervention, which is finerenone. It significantly reduces yung bad outcomes when it comes to diabetes kidney disease. Do we have any new knowledge if there is a possibility of still reversing those kidney abnormalities, sir?
Yes. Yung mineralocorticoid receptor antagonists, we have two of them already, no? Spironolactone and eplerenone, or Inspra. They also can correct some of the abnormalities in diabetic kidney disease, but not as much as finerenone. However, finerenone has to be used also early in the progression of the chronic kidney disease. It's no longer beneficial when the glomerular filtration rate is 2.5.
I see. Sana dadating din sa atin yung gamot na yan, sir.
Napakamahal.
Oh, I see.
Napakamahal.
Hey,
I have several patients on finerenone whose drugs were bought in the United States by their relatives. Although some of them have patients who have doctors, relatives, no? Binibigyan pa nila ngayon ng mga samples yung mga doctors sa States.
I see. Well, kung mahal yung finerenone, baka sir, baka mas mahal yung tirzepatide.
Persepatide, oh nga.
Tirzepatide.
Siguro sa umpisa, oo. Kasi mahal ang Ozempic, no?
Yes.
Lalo nang mas mahal yung yung tirzepatide.
Tirzepatide. Well,
Yung 2.4 milligrams, para sa weight talaga yon, yung Ozempic na 2.4 milligrams, hindi pa rin dumadating sa atin. Pero that is the semaglutide that is really for weight loss. Yung nasa atin is for diabetes. Yung 1 milligram.
sana darating sa atin na mas mura. Well,
Yeah.
here is a question from the chat box, no? Balik tayo sir doon sa MAFOLD. Sa MAFOLD, and did they mention anything about pioglitazone as the first line of treatment? Sa
No,
MAFOLD?
they did not describe the treatment for MAFOLD, only the reasons for the change in terminology. Pero I still believe, the Fronso still believes that pioglitazone is a very good medication for MAFOLD, NAFOLD.
Very good. And now perhaps, baka ito na yung last question, no? From Dr. Cruz. He's asking, do we have new treatment for pre-diabetes so it will not progress to full-blown diabetes? And sabi nga ni Sir na pre-diabetes is early diabetes already. And that alone is already very significant. Yet,
Yeah.
Sir, sagutin natin yung tanong niya, Sir. Is there new treatment regimen for pre-diabetes?
No, wala tayong new treatment. But let's take a look at the history of type 2 diabetes. What is the first abnormality and which persists for the lifetime of the patient? It's insulin resistance. So pioglitazone pa rin. Weight loss pa rin.
That's right, Sir. Ngayon ko talaga na-appreciate sa lecture niyo, Sir, yung treatment of pre-diabetes as early diabetes.
Oh,
I
so
think-
there is something that I'd like to explain. Baka there is some confusion. Yung retinal dilatation of the arteries, di ba? Maganda yun, kasi it will supply a lot of blood to the organs. But here, retinal vasodilatation is a reflection of the neuronal degeneration. So parang paralyzed yung nerves. So there is a perpetual dilatation of the arteries which is then followed by venular dilatation. Wala na yung constriction, dilatation ng mga arteries. Perpetually vasodilated na sila.
And if that happens in the retina, it may also happen throughout the body, Sir.
Yes, and it is one of the reasons for depression.
Meron pa bang mga questions? I think we have cleared all the questions that I believe are very significant. All of them are important questions. O Sir, na-storbo namin kayo, Sir. Sorry. At ginabi tayo. Marami nagtanong, sir eh. But we are always very thankful for our guest speakers, especially to you, sir. At marami kaming bagong natutuhan ngayong gabi. Thank you very much also to our sponsor, GDM, who is gracious enough to help us push through this activity. So with that, I would like to thank everyone, including the first lectures, Dr. Baldemore, Dr. Marcy Cruz, and of course, our favorite speakers, Dr. Litonwa, for being us tonight. Thank you very much, sir. Doc, thank you.
Salamat, Ned, for inviting me.